So, in this section, I will talk about perioperative myocardial injury or infarction in patient coming for non-cardiac surgery. Now, perioperative myocardial ischemia or infarction presents very atypically, different from the normal population because patient is under anesthesia or post anesthesia. So, presentation may not be very typical. So, we need to have a high risk of a let's say high index of suspicion to make a diagnosis and do early management, because perioperative myocardial injury or ischemia or infarction increases the risk of morbidity and mortality in patient from many folds. So, in this section, we will discuss all the what are the risk factors, how do we evaluate these patients, what is the diagnosis, how do we make the diagnosis of perioperative myocardial ischemia or infarction, and what should be our management protocol. So, let us start our discussion with a case scenario. So I received a patient who was a 75 years old male. So first thing was the patient was 75 years. So is age a factor increases the risk of myocardial ischemia or infarction? We will see. Then patient has a history of stable angina on medication. So patient has a history of coronary artery disease. So whether a history of coronary artery disease increase the risk or not, we will see. Then patient is posted for total knee replacement, that is a non-cardiac surgery. And he has also a history of diabetes requiring insulin for control. So patient has a comorbidity in the form of diabetes requiring insulin for a blood sugar control. So whether diabetes increases the risk or not, we will see. So we have to calculate what is the risk of perioperative myocardial ischemia or infarction in this patient, and how do we evaluate this patient in perioperative period. And this is what we are going to discuss. So first of all, why does the perioperative myocardial ischemia or infarction happens in a patient in a patient? Now, mostly it is due to imbalance between myocardial oxygen supply and demand let's say in a patient with underlying coronary artery disease, or due to acute thrombus, disruption of acute thrombus, or a coronary artery plaque disruption. And as I earlier said, the presentation may be very atypical. The typical clinical features patient may not complain under anesthesia of chest discomfort, etc. Then typical ECG changes may be missed. In a lot of patient, only elevated troponin level is what we will find. So what we will discuss, what is pathophysiology of myocardial ischemia or injury in patient coming for non-cardiac surgery. Then we will discuss what are the patient who are at high risk factors, and how do we evaluate these patients, what are the diagnostic criteria that the patient has to fulfill to make a diagnosis that it's a case of perioperative ischemia or infarction, and what is the management and long-term prognosis of these patients. Everything we will discuss. So what is the pathophysiology? Now, the stress of surgery can lead to myocardial ischemia or infarction via multiple mechanisms. What are the main mechanisms? Coronary artery plaque rupture, or it could be myocardial demand ischemia. Supply is less, demand is more. So myocardial demand ischemia, right? So these are the two important factors, and interplay of these factors can cause myocardial ischemia and infarction, right? So what is the incidence of myocardial ischemia or infarction in a patient presenting for non-cardiac surgery? So the incidence has been calculated in some of the studies, and patient above 45 years of age coming for inpatient in hospital, that is, patient is not operated on the basis of ambulatory surgery, it is in hospital. For in hospital surgery, right, in hospital admission for any non-cardiac surgery, non-cardiac surgery requiring the admission of the patient, the incidence has been found to be 15 to 20%. So this is a pretty high incidence, and the age is hardly above 45 years of age. So what are the risk factors? What are the patient in whom the risk is higher? So we have to evaluate those patients in a more careful manner. So what are the risk factors? As I said, age is one of the very important risk factor of myocardial ischemia and infarction. Age above 65 years, the risk is higher. So first is age. Age above equal to 65 years, the risk is higher. Then, if patient has any underlying coronary artery or peripheral arterial disease, like in our patient, the patient was 75 years, so this was the risk factor present. Then patient has a history of angina, then has an underlying coronary artery disease. So there were two risk factors already present in the patient. So patient having history of coronary artery disease, or peripheral arterial disease, peripheral arterial disease. Now, patient having history of diabetes or kidney dysfunction. So, our patient also had a history of diabetes requiring insulin for control. So, patient having history of diabetes or kidney dysfunction, right? So this is again the third risk factor which was present in our patient. Then the fourth risk factor is patient who already have an elevated BNP or pro-BNP present in them. So a lot of patient, if the BNP level has been done and they have a baseline elevated BNP level, they are at a higher risk. So elevated N-terminal pro-B type natriuretic peptide, right? Then patient already having in ECG STT changes, baseline STT changes. So patient with baseline T wave changes. Then major patient undergoing surgery in which there was a major perioperative hemorrhage leading to a prolonged hypotension in the patient. So, major perioperative hemorrhage, right? And surgery, type of surgery. Emergency surgery always has a higher risk, right? So, type of surgery. So, emergency surgery always has higher risk, right? So these are the important risk factors. Age above 65 years, underlying coronary artery or peripheral arterial disease, then patient having history of diabetes or renal dysfunction, patient with an elevated BNP, pro-BNP level, then patient having a baseline STT changes, and the patient having a, let's say, heavy major hemorrhage in periop period, and patient coming for emergency surgeries. These are the patient at a higher risk. But there are some risk indices factor calculator also, which help us in estimating the risk of the major cardiac event in presence of some underlying independent predictors present in the patient. So one is revised cardiac risk index, let's say risk indices predictor. So revised cardiac risk indices predictor, right? This has six independent factors which help us in estimating the risk of cardiac event associated in a patient coming for non-cardiac surgery. So what are those six independent factors? The first one is the high risk type of surgery, like vascular surgery or open intraperitoneal or intrathoracic surgery, in which would be a huge fluid shift. Then history of ischemic heart disease, patient having history of myocardial infarction or positive exercise test or current complaint of chest pain, right? Patient on, let's say, therapy, nitrate therapy, etc., because had a history of myocardial ischemia infarction. Now patient having history of heart failure, Patient having history of cerebrovascular disease and diabetes mellitus requiring the insulin treatment, and patient having preoperative serum creatinine level above 2 milligram per deciliter. So all these are the 6 independent factors for prediction of risk. And if there is no risk factor present in the patient, the risk of cardiac death, non-fatal myocardial infarction or non-fatal cardiac arrest is only 0.4%. And as the risk factor is increasing, like if someone has 3 or more risk factors, as in our patient, we had 3 risk factors, right? The risk of cardiac death, risk of non-fatal myocardial infarction, and non-fatal cardiac arrest is 5.4%, right? And again, another study used the 6 independent predictors for predicting the rate of myocardial infarction, pulmonary edema, ventricular fibrillation, and primary cardiac arrest or complete heart block in presence of these underlying risk factors. If no risk factor, the risk is 0.5%. If more than 3 risk factors, the risk is 9.1%. So this is revised cardiac risk indices. Let's say a risk indices predictors used for predicting the risk of cardiac event in patient coming for non-cardiac surgery. Okay, so we can use these indices to estimate the risk of a cardiac event and take proper precaution to prevent it. Okay, then if a patient undergoes a perioperative myocardial ischemia or infarction, what would be the clinical features? As earlier I said, the clinical features under anesthesia is very much masked, very difficult to make a diagnosis. So patient may have a typical sign and symptoms. So we are talking about perioperative period. So even post-op period we are covering. So patient may present with a typical sign and symptoms of chest discomfort, typical ECG changes, but most of the patient does not present like this because of the effect of anesthetic agent, because of the effect of analgesic agent which has been given, because of the effect of amnestic agent which has been given. The clinical features are number of time muted or masked or atypical, right? Most of the patient, we miss the ECG changes, and the only thing which we get, if we get a troponin level done, elevated troponin level, right? So patient may have sign and symptoms like any patient with acute coronary syndrome, but due to influence of anesthetic, analgesic and amnestic agent, but due to influence of anesthetic, analgesic and amnestic agent, just midazolam also. The symptoms may be muted, atypical or absent, or maybe typically absent in the patient. Now, ECG signs of MI we may miss, right, may not be recorded in these patients. Now, ECG signs may also be missed. So, in majority of patient only increased troponin level is what we will get. So, in majority of patient, increased serum troponin is the only clinical feature we will get, right? And there was one very important trial, the international POISE trial. Now, this evaluated 415 patients who had a perioperative myocardial infarction, and approximately in 65% of the patient did not experience any ischemic symptoms, right? So we have to have a very high level of index of suspicion in a patient with many risk factors. We have in patient with a higher risk of developing the cardiac fatalities. We should have a high index of suspicion, right? How we will evaluate these patients? Now, if patient presents with a typical clinical feature of myocardial ischemia and infarction, the evaluation is same as we do for any other patient, the ECG, the serial troponin, etc. But during anesthesia, as I said, patient may not present typically, and there may be number of other complication which may develop and also present in a similar manner, we may require some higher additional investigation to delineate the cause, right? So, patient with typical symptoms are evaluated in similar manner, are evaluated in similar manner as any patient presenting with these symptoms. Caution should be practiced, caution in perioperative period, because number of other complications will mimic myocardial infarction and ischemia. Caution in perioperative period as number of other conditions like pulmonary embolism, other conditions can mimic myocardial infarction, right? So, we may require additional investigation. So, additional investigation may be required, right? Like cardiac magnetic resonance imaging, etc., right, to make the diagnosis. Okay. So, what would be the routine way of evaluating the patient presenting with a typical clinical features? So, we get a 12-lead ECG done immediately if patient is complaining of chest pain or any kind of typical feature, any kind of discomfort. So we get a 12-lead ECG done and repeat it every 15 to 30 minutes if initial ECG is non-diagnostic, but the clinical suspicion remains high. So this is same as we do in any patient presenting with the typical clinical feature of myocardial ischemia and infarction. Now, when we diagnose STEMI, that is ST elevated myocardial infarction, if more than 0.1 millivolt or more than 1 mm elevation in all leads other than V2 and V3, right? And for leads V2 and V3, we need a more than 2 mm of elevation in males and more than 2.5 mm elevation in males above 40 years, let's say in less than 40 years of age, and more than 1.5 mm elevation in females. If ECG suspicious but not diagnostic, repeat ECG every 15 to 30 minutes and consult the cardiologist as early as possible. If for non-STEMI diagnosis, 2 anatomically contiguous leads with presumed new horizontal or downsloping ST depression of more than 0.5 mm, right? And T-wave inversion may be seen and or a prominent R or RS ratio more than 1. If any of these, we can go for non-STEMI. Now, we will immediately get a cardiology consultation done if patient presents with cardiogenic shock or heart failure or having a sustained ventricular tachyarrhythmia. This could be the complication of STEMI or non-STEMI. So we get our ECG, serial ECG done. We get the troponin level done. What could be? We get the troponin level done. Number of time in post-op patient or peri-op patient, troponin would be the only elevated thing that we will get. So we get the troponin level done, right? Okay, and we repeat troponin every 2 to 3 hours in case of high degree of suspicion. And if by chance we have a pre-op troponin level, we try to compare it with, or we compare the troponin from the serial troponin. We compare the serial troponin level. Okay, now additional test in case of patient in peri-op period, we may require some additional tests because in number of patient, the troponin level can be elevated due to other causes, like if patient has a pulmonary embolism, or if patient has a chronically elevated troponin level, or if patient having a sustained atrial fibrillation, the troponin level will be elevated in absence of myocardial ischemia or infarction. So we may need a additional test done, like we can get a echo done in the patient, we can get a radionuclide myocardial perfusion done, we can get a cardiovascular magnetic resonance imaging done. This all can help us in making diagnosis. Now, what are the other potential causes of increased troponin level? So we can get increased troponin level in some other conditions which can mimic the clinical feature of myocardial ischemia or infarction, like pulmonary embolism, like in sepsis, like rapid atrial fibrillation, or patient may have chronically elevated troponin level. So we have only troponin cannot again be diagnostic. We have to get a serial troponin level done, and we may require some additional tests.